Good afternoon. I'm Ann Dunkelberg with the Center for Public Policy Priorities. I did send you around a short bit of written testimony that the clerk has. And I really just wanted to take a few minutes to thank you for the hearing and to lay out the provisions of the Affordable Care Act that are already under implementation and some of the benefits that Texans have gotten today. The first part is the pre-existing condition insurance pool, which added a second high-risk pool in every state and added to our existing high-risk pool, is now covering just shy of 50,000 Americans and about over 4,000 Texans. As you know, young adults can now stay on their parents' insurance policies up to the age of 26, and nationally it's estimated from the statistics that are available that about 2.5 million Americans 19 to 25 gained coverage that way in 2010. And that's the only age group that had a statistically meaningful reduction in their uninsured rate last year. So there was it really made a difference for kids in that age group. More than 120 of Texas' largest employers, including the State of Texas Employee Retirement System, as well as AT&T, American Airlines, Southwest Airlines, and Texas Instruments, have already received over $425 million in federal support to reduce the cost of their early retiree health benefits. As you know, insurers today can't deny coverage to a child based on the child's pre-existing condition. And as you've heard, we've benefited from having for the first time a consumer health assistance program housed at the Texas Department of Insurance that helped thousands of Texans with their health insurance questions this year. Small employer tax credits of up to 35% of a small employer's cost of coverage are in effect right now, available to small employers with fewer than 25 workers and that have a fairly low average wage. Year-to-year health premium hikes, as you've already heard in the earlier testimony, are now subject to review by TDI and by the federal government to make sure that they're not unreasonable. That's new. And as you also know, as of this year, all of our individual, small group, and large employer regulated health plans are subject to a requirement that they have to be paying out 80 to 85 cents of every premium dollar. And this summer in Texas, individual, small businesses, and larger employers will be getting rebate checks from those so-called medical loss ratio refunds. Over 1.4 million Texans in 2010 got a Medicare checkup or other preventive care service without having to pay a deductible or copayment for the first time. Over 103,000 Texans in Medicare got discounts worth just shy of $59 million in 2010 on their brand name drugs. I'm sorry, that was actually in 2011, on their brand name drugs while they were in the donut hole, the coverage gap for Medicare Part D, and that's an average savings of about $565 per person. And Medicare Advantage and Part D drug plan prices both dropped in 2010 and 2011, 2 years in a row, so it's helping us somewhat with those premiums. I did add another handout that I sent around, and it was really only to provide some additional information on the much broader topic that the opening speaker. And really, I'm not going to take time because there are lots of folks who want to testify, but this last graphic, I think, is one that adds to some of the very sobering information that he gave us. It is the Organization for Economic Cooperation and Development countries, and it just shows how wildly out of whack the United States is compared to every other industrialized country in terms of our expenditure on health care as a percentage of GDP and per capita. And I think that one of the reasons that I find this graphic both sobering and encouraging at the same time is that while it means that we are spending way too much of our society's resources on health care, it also means we probably don't need to spend any more than we are right now. If all of these other countries, and as one speaker pointed out, you never hear anyone complain about Switzerland or Germany having a bad health care system. Lots of other very well-to-do industrialized countries with good health care systems are getting by on much smaller percentages of their GDP and much smaller per capita expenditures. So while it shows that we're going to have to work really hard to change some of our bad habits in our health care delivery and consumption habits, I think it also provides us some hope that we can get there. So I didn't want to go without having anything to say about that opening presentation, which was very important. I appreciate the opportunity to speak. Thank you.
And thanks. Any questions? Vice Chair Nisha.
Thank you, Ann. Were you here for the presentation by Dr. Thomas Saving?
I was. I won't pretend that I understood all of it.
Well, there's one of the slides just raised some questions, and it's number on page 20, reduction in Medicare benefits per beneficiary. Reduction in Medicare benefits. And in your opinion, will Medicare benefits decrease due to the Affordable Care Act?
The Affordable Care Act added a lot of benefits to Medicare, expensive benefits, like reducing the size of the donut hole and adding preventive care benefits that weren't covered before. It didn't used to cover a checkup, those sorts of things. So it has added benefits. It has also put in some pretty hefty mechanisms for reducing the increase in the growth rate in Medicare spending. And I will say that one of the more discouraging things for me as an advocate is that I've had to listen to people on both sides of the aisle describe that kind of thing. If the other party did it, you call it a cut, and if you did it, you call it bending the curve. And I literally have heard both sides point the finger back at each other. There's no way to get healthcare spending and deficits under control without reducing the rate of growth in Medicare. So what's in the ACA does not reduce Medicare below what it is, spending below what it is today, but it does say it can't keep growing as fast as it does. And, there are many, many, many things in the presentation this morning that I certainly agree with. I think, and I don't know that the scenarios that he laid out are often things like if you relied on one tool alone to balance the books, this is what you would have to do. Or if nothing else changes and the only way you can get a comprehensive health benefit is to spend exactly as much as you do today or growing just as fast as it is today, then this is how far off you would be. So yes, a lot of things have to change. The inflation rate of healthcare has to change. Many other things have to change in order to continue to guarantee a comprehensive benefit to seniors, but at the same time getting healthcare spending. I think, the bottom line is things cannot stay exactly the way they are today. And I think most people understand that. But it is certainly not the case that the ACA cuts Medicare spending per beneficiary below what it is today in any sense of the word. There's so many things I could I think Dr. Savings, one of the blog postings that we went and read of his, basically explained that the ACA spends more per beneficiary than the Ryan budget that the House voted on last summer does. So, I mean, there are a lot of proposals out there, as he noted, to reduce the growth trend in Medicare, and the ACA is part of that picture, and it did include $500 billion $500 billion over 10 years in Medicare reductions from a whole variety. But that is reductions for bending the curve. It's saying instead of it growing that fast, it's going to come down there. And that even bending the curve means somebody is making less money. There's no two ways about it. And there is no doubt, as Dr. Savings said, that is a really challenging thing, and that it is not one that is supported by politics. It's almost like you need a base closure commission to do that kind of thing. It's going to be painful for people on either side of the aisle to make those things. And as an advocate, my concern is that I want to see that done by people who have an assignment of balancing, of taking a balanced approach to that. So they're balancing it from spending reductions, they're looking to see whether they need new revenues and those sorts of things, and they have a task of making sure that seniors are afforded a decent standard of care and aren't going to have to go without basic health care needs or choose between life and death. So that was a long answer, I'm sorry.
That's okay. Let's assume that the changes in Medicare will be expensive. Isn't there a lot of federal money that we would draw down? Can you comment on that?
I may not understand your question. I'm sorry. Could you repeat it?
Well, let's say that we're going to have changes to Medicare which will be expensive. aren't we also going to have an opportunity to draw down a lot of federal money to?
I'm wondering if perhaps you meant Medicaid. Certainly, because we do have two different things. Our Medicaid, the Medicaid changes in the ACA, we have focused often on just the state GR responsibility in that change, which is not insignificant. You know, even though the federal government, as was noted, pays for the first 3 years of the expansion and then phases in a state responsibility that never exceeds 10%, you do have what I ran after Mr. Milwee to say, I sure wish I could convince him to use the term welcome mat effect instead of woodwork effect, because we all know what comes out of the woodwork. It's vermin, and we don't think any of the folks who are going to get on Medicaid, those children are vermin. But anyway, the welcome mat effect will be real, and that is not something we get a special match rate on. So there are certainly going to be additional state costs, and that's nothing to be dismissed. We need to have the means to cover those costs, but we often forget to mention that if the Texas cost from 2014 to 2019 is just under $6 billion, as one of the more recent HHSC estimates said, that the federal match for those dollars would be around $74 billion that would be coming in. So, you know, the state level economic impact from the Medicaid piece is something that's a different picture, maybe a little bit easier to calculate than this much bigger question of Medicare and how we will control that over the long haul.
Thank you.
Thank you. Any other questions? And I like this chart. I've referenced something like this in the past about our expenditure per patient. Only thing is, and I get frustrated, maybe you can send me to a source. Some of these countries are very small in size, and so it's kind of like comparing a global waiver in Rhode Island to Texas.
Right.
And so I'm kind of wondering if we could get any information on India, China, or Russia, and if you could just direct me to that, that'd be great.
Yeah, I will have to look for that. I don't know that I've ever seen it for the big non-OECD countries, but I think it's an interesting question.
Yeah, as we wrestle with this, I've not seen this chart exactly like this, but I've certainly studied these numbers and I'm very concerned. But I referenced with Judge McCown the other day that I had a chance to sit down with the Secretary of Foreign Affairs from Denmark, and we had a great conversation about health care, but that their numbers are dwarfed by ours. Chairman Coleman.
Yeah, just following up to that, the whole idea is that we're inefficient in terms of how we buy health care, and it costs more than it should in terms of how we lay things out. Now, particularly on the Affordable Care Act, the changes in Medicare, that presents a lot of savings based on what I laid out a little bit earlier, because finally the Medicare ends up being a medical home when it has never been. Would that be correct?
Well, that's certainly the goal. As you know, there are accountable care organizations being rolled out and piloted right now that are very similar in concept to some of the stuff that we're trying to do here in Texas. And so, I understand Dr. Saving's skepticism about how successful we're going to be with that until we get there, but there certainly is an intention to try to find a way to create financial incentives that don't reward either the over or under provision of care, and that's all we have to do.
Now, importantly, we've done this with seniors in Medicaid once before, haven't we? As you know, we used PCCM, which was a primary care case manager in an office that was paid a certain amount per month to see any Medicaid patient in there, and there would be seniors in that. And that was before what's the name of that thing we have now? It's piloted in Houston. I can't think of the name of it.
Star Plus?
Star Plus. Yeah, Star Plus. But prior to that, we used a very similar model. And we used a similar model because what we found were, particularly among seniors, regardless of whether they were, wherever they were, it was the chronic conditions that were making was really our problem. That if someone broke their hip, that was a real problem. If someone ended up with glaucoma, broke their hip, and had asthma, that was the real problem. And then add cancer on that, and that we had a bigger problem. So this isn't something that this state hasn't done any differently, in that we were actually on the cutting edge of primary care model of actually providing a primary care provider for people in Medicaid, including disabled, elderly, and children and adults.
Yeah, I think we've tried to keep up with changing those models with the times, and I think that the step that we're looking to now, both with our new 1115 waiver as well as with our new state programs and some parallel activities on the federal front, it is the notion that healthcare entities are going to have to demonstrate that they are reducing bad outcomes and cranking out some better outcomes in order to be profitable, and that was the piece that we just haven't had in our system before. So
right.
We'll see, and we hope that will be effective. We're pretty early in that game.
Representative Schwartner, and then I think we'll go on to our
Thank you, Madam Chair. There was a comment in reference to the reason one of the GDP differences between what U.S. spends, a percentage of GDP versus other countries, was the inefficiency, and I agree with that. There is inefficiency, obviously, in healthcare. But would you not also agree that our population is, in a lot of ways, much less homogeneous than other countries? In addition, other countries limit access to care and ration care and limit the types of care they provide at certain age groups, both neonatal as well as end of life, as one of the reasons why the GDP differences exist between countries?
I think my response to that would be that those are that should be studied. I don't know if the heterogeneity here in the United States compared to the Germanys and Switzerlands away all that difference, because it's a pretty gigantic difference. I'd be very surprised if it were enough. And again, as I noted, some of those wealthier countries clearly aren't rationing care. So I think that it's important to understand that those could be part of it. I have yet to see any analysis that would answer our question about what role they play. I wouldn't reject them out as hand, though, as things that would have an impact on it.
Would you say the iPad that's been set up under the Affordable Care Act would be one mechanism which they might be able to control costs by limitations of the types of services or cost structures of those services?
That's certainly the intent of the IPAB, which is the committee, but basically, yeah, it's like a base closure commission for Medicare, and the idea being that it's supposed to be insulated enough from political pressure that it can actually make some of those hard decisions. And again, there's folks trying to get it watered down every day, who's, I'm sure there are lobbyists whose only job it is to try to get the IPAB removed. So, we have a tough challenge. It's when you're used to being able to get whatever health service you want when you want it because the commercial sounded good or whatever, and because everybody had a bypass, so you must need one too. It's hard to change those habits, and one man's effective care that's actually based on science and outcomes is another man's rationing, and so this is not an easy kind of change to take part in. It's certainly not in the world of politics.
Thank you.
Thank you, members. Appreciate it.